everybody. My name is Jeannette Hart, and I am a PA. I am practicing in Washington State, and I work at Cadleck Regional Medical Center. I am now the co-owner and co-founder of Pacific Northwest Arthritis and Rheumatology. Today, with this journal club, we'll be discussing Sarilumab for relapse in polymyalgia rheumatica during glucocorticoid taper. So first, let's take a step back and discuss PMR. First of all, most of our PMR patients, or at least half of our PMR patients, may have a relapse during the tapering of their glucocorticoids. Patients with PMR who have relapse while tapering glucocorticoid therapy or have a glucocorticoid adverse effect or a side effect while taking them really have limited treatment options. Earlier studies suggest that IL-6 blockade may be clinically useful in PMR. What they've seen is that circulating elevated levels and increased tissue expression of the interleukin-6 is identified in patients with this condition. Sarilumab is a human monoclonal antibody that binds to the IL-6 receptor. So let's talk about the SAPHYR trial and this study. The FDA approved the first treatment option for PMR outside of glucocorticoids. This study was to determine the efficacy and the safety of Sarilumab for the treatment of PMR. This was funded by Sanofi and Regeneron Pharmaceuticals. So we'll start with the inclusion criteria for the patients in the SAPHYR trial. These patients had to meet the 2012 classification criteria for PMR. And this was a scoring system that looked at whether or not the patients had morning stiffness for greater than 45 minutes in 2 locations. They had to have hip pain with limited range of motion, negative rheumatoid factor and anti-CCP, and other joint pain. They could have an ultrasound that showed subdeltoid bursitis, biceps tendonitis, synovitis in their shoulders and their hips. So using some of those and stratifying and scoring those, the patients could be diagnosed with PMR. So of those patients, if they had greater than 1 recent flare during that glucocorticoid taper at a dose of greater than 7.5 milligrams a day, prednisone or the equivalent, they could be included. They had to have a history of at least 8 weeks of greater than 10 milligrams of prednisone per day or equivalent. And then lastly, their SED rate had to be greater than 30 or CRP greater than 10 within 12 weeks before the screening of the study. Exclusion criteria included a diagnosis of giant cell arteritis, rheumatoid arthritis, or any other inflammatory arthritis. And then we can break down the study design. So first of all, this was a phase 3 trial. It was double-blinded and multi-centered in 60 sites in 17 different countries. It was a randomized control trial, and they assigned the patients in a 1-to-1 ratio for a 52-week study. First, the patients were all put on exactly 15 milligrams of prednisone for 2 weeks so that all of the patients were adequately controlled going into the study. And then the patients were put in 2 different arms. The Sarilumab arm, so the patients, I'll restate that. The patients were put in 2 different arms. Sarilumab, 200 milligrams every 2 weeks, plus a 14-week glucocorticoid taper, or placebo, plus a 52-week glucocorticoid taper. So in the Sarilumab arm, the patients could be reduced to a 150 milligram dose if they were noted to have neutropenia, thrombocytopenia, or elevated liver enzymes. Then the patients were assessed every couple of weeks, moving through the study, then every 4 weeks, and eventually made it out to that 52-week end of study. They were assessed again at 58 weeks and then 6 weeks after the study period. Patients who did not have disease remission or who had disease flare within the initial 12 weeks were allowed to add on prednisone roughly between 0 and 5 milligrams a day to their blinded taper. If the add-on prednisone was discontinued before week 13, patients could continue in the study. Patients who were given the steroid rescue therapy after week 12 were deemed, however, to have no response and were then excluded. For both arms, methotrexate could be on board as long as it was less than or equal to 15 milligrams per week, and if it was a stable dose for at least 3 months before baseline. There were only 5 patients that were on methotrexate in the Sarilumab group and 10 in the placebo group. There were a few patients on other various DMARDs, but very little. 2 patients on lislenamide and 1 on hydroxychloroquine and azathioprine. So we're looking at the primary endpoint. We're looking to see whether the arm with Sarilumab patients could get sustained remission by week 52, or if the placebo arm using the longer glucocorticoid taper could reach remission by weeks 52. Remission was defined as resolution in signs and symptoms of PMR by week 12 and sustained normalization of a CRP level absence of disease flare, and then adherence to the prednisone taper for the weeks 12 through 52. The definition of disease flare is a reoccurrence of symptoms or an elevation in inflammatory markers from active PMR, resulting in an increased use of glucocorticoids. Secondary outcomes were also looked at, and these really just were each of the components of the sustained remission. And then they looked at the cumulative glucocorticoid use during the 52-week period, time until their first disease flare after clinical remission, and then the composite glucocorticoid toxicity index score. And of course, safety was evaluated. So in the end, 280 patients were enrolled in this study. It was a smaller sample size because this was during COVID and they had to close enrollment at a period of time. A total of 78 patients completed treatment, 42 in the Sarilumab arm and 36 in the placebo arm. As far as the primary endpoint went at week 52, 28% of the patients on Sarilumab made it to remission versus 10% in the placebo arm. So 18 percentage point difference with a p-value of 0.02. Okay, that concludes our discussion about Sarilumab for relapse and PMR. And I encourage you, if you have any questions or want more information, to go ahead on the RAP app or RAP website. Thank you.